Okay, so I am Shari Upstill. I'm originally from North Carolina. I've been a PA since 1996, which is just way too long for me to even fathom. Spent most of my time in the emergency room for Wake Forest University emergency physicians. That's where my heart is, and that's what I'm doing here. I work at the ER in Gore, which is the one emergency department that has allowed us to come in and showcase what we do. And so far it's been a great success, and lots of good feedback on that. So physician assistants, some of you have heard of us, some of you haven't. Medical professionals, we've been trained in the medical model as opposed to some of the nurse practitioner that has nursing background. When we practice, it is always with our physician-led team. We're a collaborative medical team, and that's how we view what we do as physician extenders. PAs treat patients autonomously, collaborate with doctors when necessary. I can tell you in my emergency room, we have the acuity scale of 1 through 5. 5 is your fast track. Lots of PAs run the fast track. I was in the acute care area. In anything 3 and above, my physician was actively participating in that patient care. And that's how we work. As you gain experience and as your physician knows what you can do and trusts what your opinion is from a medical standpoint, I got to be able to be a little more autonomous than people that we hire as new grads coming out of school. So, you know, we're trained to be flexible. We're trained to, you know, work as a team. So, brief history PAs. They came around in mid-1965. The first program was at Duke University in North Carolina. And it was a way of addressing the GP shortage, but it was also a way of finding a home for our Navy corpsmen that came back with some experience in medical care, but really to integrate them back into civilian life, and this just became a fit. So that was a large part of the first class or two. The 70s, we saw more regulation as needed. The medical community, federal acceptance, we became regulated as a profession. American Medical Association recognized us. All of us are, our regulatory board is the medical board per state. Each state has their own, and that's where we go through to get our licenses. We all have to have the certification that comes with an exam that is put on and administered and updated regularly by the National Commission on Certification of Physician Assistants, the NCCPA. And if we don't have that accreditation or that certification, then we don't practice. We have to have that to get our licenses. And then accreditation, we have the Accreditation Regulatory Commission that sets what our competencies should be in our education. So we get it from everywhere. We're well trained. So what can we do? We can do most anything. Obtain medical histories, physical exams. I can order and interpret the labs that I think are beneficial. I usually will present those to my physician, supervising physician, come up with in the more sick patient. We can diagnose and manage. Part of that is writing prescriptions. We have full prescription capability in the US. And we have that right in all 50 states, the District of Columbia, all the territories, and all the military uniformed services. And we have the ability to write controlled substances with an additional license from the Drug Enforcement Agency. We can perform minor surgery, your lacerations, your abscesses. Again, your experience can lead to other things. There were PAs in the ER where I worked that installed central lines. We did LPs, we did chest tubes. It's all about developing a scope of practice and a relationship with your physician for the best patient care outcome. We're active in patient education. Our scope of practice responsibilities correspond to our supervising physician's practice. So we can see, as I was saying, we can see all all range of patients. And you're going to start off with a PA that's going to see the lower acuity, the bread and butter patients, the child with a fever, and then they can build up with that relationship and that experience, and it's all per you and your your health team that you are part of. We're trained to know what our limits are. If we have a sick patient, we will go and ask questions. We're not going to we're not doctors. I'm not trying to be a doctor. But if I know how to take care of a patient and I'm confident in that, my physician is confident in me in that, I'm good. I ask a lot of questions. I've been doing this 27 years. I still ask a lot of questions of my participating physicians. And that's the way it is meant to work. So training, it is an intensive, it's a master's level program. Have to have a bachelor's. We do prerequisite science courses, much like pre-medical students do. And we have to have patient contact hours. I got mine by being an orthopedic tech and a phlebotomist. We have respiratory therapists that go on to PA school. Any kind of patient contact is going to go toward that 2,000 hours. And PA programs are very competitive. There are over 300 programs in the US right now. There's 31 in the UK where they're not even regulated yet. There's only 3 in Canada, so UK and US are leading in PA education, and they're all pretty similar in their requirements. PAs were trained in generalists, as I said, in the medical field or medical model. And then the first year is classroom training. It's our instruction. It's in everything, in every body system, pharmacotherapeutics, ethics. And then after that first year, the first didactic portion, we do over 2,000 hours in clinical rotations in general settings, internal medicine, cardiology, surgery. We have electives if we know what area we really want to practice in, but by the time we're done, we have over 2,000 hours of experience in taking care of patients. And we're taught to be versatile. You can come out as an emergency medicine PA and you can decide you want to do gastroenterology, but you're starting back over at square one. You learn the ropes, you move up, but we're trained to be versatile in that way. So that certification that I was talking about, National Board Certification Exam through the NCCPA, and similarly in the UK, it's the Faculty of Physician Associates. It's a long, rigorous, challenging multiple choice exam. In the UK, the OSCES is a performance portion. We used to have that in the US where they would meet patients in mock settings and that would be part of your exam. They don't do that in the US anymore. As of, I think, 2013, it's all by test. And to maintain that certification, we have to get 100 hours of CME every 2 years. 50 of that can be through reading through Category 2. 50 of it has to be Category 1, where we attend conferences or we have hands-on training. And then we take a recertification exam. It is now every 10 years in the US. It used to be 6, as it is in the UK. So the bulk of the PAs are in the US. There are 168,000 PAs in the US right now. The UK is cranking them out in their 30-some programs. They're due for regulation in 2024. And then they will be regulated and that profession will continue to grow there. But we can practice, or we are practicing in each of these countries in limited fashion. So we're growing. We're not going anywhere. So UK PAs in regulation, the 31 programs, they're having more open up. National exams and a voluntary register like we already have in New Zealand. Much like the US, the national exams to make sure that we're proficient in what we're doing and that we're safe to be in that health team. July 2019, or 2018, government announced plans to regulate. 2019, the GMC became the regulatory body of the PAs. 2024 is when they should be regulated. And then we started bringing over UK PAs to New Zealand. So there are already 3 here? 2. So I'm going to turn it over to Shelly, and she's going to talk more about PAs and they're getting established in New Zealand. So thank you for listening to me.
Thank you very much.
Okay.
Okay, I'm Shelly, like I said earlier. I've been a PA for about 18 years, and during that time I've worked in lots of different areas, mostly general practice, but I did spend 2 years in an ORL head and neck cancer group. I've done a little bit of inpatient palliative care, some urgent care, and then I spent several years doing PA education at a PA university. My family and I moved to New Zealand January 1st, 2020, which in hindsight was pretty good timing on our part. And we've loved it. The first year we were here, we lived in Kaitaia in the far north, and I practiced in a clinic up there. And then in 2021, we moved to Papakura, and I practiced in the GP clinic, Papakura East Medical Center. All right. Okay, so how did PAs get to New Zealand in the first place? It started in 2010 and 2013 with 2 different pilot programs that were actually commissioned and funded by Health Workforce New Zealand. To see if PAs would be a good fit to the healthcare system. And we had 7 PAs initially that came over, a couple that worked in surgery in Middlemore Hospital, a couple in GP, we had 1 in the emergency department in Gore. And at the end of those pilots, the Health Workforce New Zealand actually commissioned Synergia, which is a third-party group, to do an analysis of how it went. And some of those findings you can actually see on those handouts that we have kind of spread around. And Synergia went out and they did surveys for doctors who had worked with them, nurses who had worked with them, admin, patients, and it was overwhelmingly positive experience from what they found. So the New Zealand PA Society was formed in 2014, and we submitted our application to become a regulated profession to the Ministry of Health in 2017, and we're currently working through that process. So I don't need to tell you guys what the healthcare process is, what the healthcare crisis is right now in New Zealand. But in 2018, the Royal New Zealand College of GPs did put out a workforce survey. Many of you may have completed that actually. And they found that up to 47% of the current GPs plan on retiring within 10 years, which is not going to help where we are right now at all. So that's kind of how we got here initially. One question I get asked a lot is, how do we practice medicine without regulation and without having a medical license from New Zealand? Which is a question I asked when I first found out we were over here as well. So we have an agreement with the Ministry of Health, and they've said that as our application is moving through the process, PAs are allowed to work in New Zealand as long as we only practice in the same area that we practiced in the pilot, which means we can only work in urgent care, general practice, or emergency departments. And the PAs have to follow certain criteria, have to have certain criteria. So one, we have to be regulated in our home country. You just heard that the UK PAs are not regulated yet, but the Ministry of Health decided once they got a regulatory authority body, which was their General Medical Council, that they could go ahead and come over and practice as well. We have to maintain our national certification from our home country. That number has to be kept on a publicly available voluntary registry, and that's one thing that the society keeps on our webpage. Maintain our own malpractice indemnity coverage, which we do, and then work only within the same scope of practice as our supervising doctor. And all prescriptions, lab orders, imaging orders, referrals have to all go under our supervising doctor's name. And so I'll tell you more about kind of how that works on a daily basis in just a second. So we can get indemnity coverage. Both Medicus and MPS will cover PAs in New Zealand. I will give a little shout out to Medicus. They have been there from the very beginning, and they were the only company that agreed to cover us initially, and they've been really great. I think every PA in New Zealand is probably under Medicus right now, but MPS has been very great as well. So where are we in New Zealand? Oh gosh, we're just everywhere, all over the place. Up until last year maybe, we were all in the North Island. We didn't have any South Islanders, but now we've got 4 in the South Island, which is exciting. And these are all the clinics where we have PAs practicing right now. The main thing that I want you to take from this picture, other than we're so popular, everybody wants one, is that we try to put PAs mostly in rural areas. So we don't want a gazillion PAs in downtown Auckland. Our main goal is to bring PAs over to work in rural areas where there really is a need for more healthcare. All of New Zealand needs more healthcare, but rural areas really, really do. And that's what our main goal is for PAs. And that's kind of how PAs have been from the very beginning. Even in the US, it's the same way. There's a greater number of PAs graduating who will go and practice in rural areas as opposed to actual doctors that graduate and where they'll go and practice. And that was kind of our reason for being in the first place. And that's kind of how we want it to be in New Zealand as well. Okay, so where we are with regulation. Oh, so we've been waiting forever, it seems like, for our application to go through. But it is moving. We are getting some traction. It's really exciting. Especially in the past year, it seems like it has really taken off. So we have gotten past the expert panel stage, and they approved it and agreed it needed to move on. We got the stamp of approval by the Minister of Health that we could move forward, and we're now moving into the targeted public consultation phase, which should last about 30 days. And then at the end of that, we can move along with the rest of it. So we're trying not to get our hopes up, but it seems like it's really moving, and that's really exciting. The next step will be to find a regulatory authority, and the Ministry of Health is working on that aspect of it. We're hoping it will be medical council. That makes the most sense to us, I think. And I think it makes the most sense to the ministry as well, but we'll have to see if they will. It is tricky. We're in a weird position because it makes sense that we'd go with medical council because our scope of practice will mirror our doc's scope of practice. So that part kind of makes sense. But then we're also a little bit allied health, sort of. You know, we don't really fit the mold too much. We don't have our own group like the nurses, so they could do, nurse practitioners. So it's a weird place to be. Okay, any other questions about that part? Okay, so you may be asking yourself, well, what's in it for me? Why would I want a PA? Better patient outcomes for one. Mainly you have another warm body in your clinic who's seeing patients every day. It decreases the patient wait time so they can get in sooner, greater patient satisfaction. I haven't had any patients in my practice who've said, I don't want to see the PA, I only want to see the doctor. And I actually have a growing list of patients who only want to see me in the clinic. They don't even want to see the doctor anymore because they know it'll be 2 or 3 weeks before they can get in to see him anyway. And so it's definitely better patient outcomes for sure. Greater efficiencies, things get done a little bit quicker. When I told you earlier that everything has to go under the doctor's name, probably the first thing you thought was, awesome, just what I need, more stuff in my inbox to have to go through. Geez, I don't want to look at all that stuff. But if you look at it the other way, actually you've got 2 people working on your inbox now. So you're doing your inbox and your PA's doing the inbox as well. And that's how it works with my supervising doc. We both look at the inbox every day, we both go through it. I try to remember the patients I knew were mine and I can put my name on it so he doesn't have to look at those. But another thing that really helps is that if he's gone on holiday or vacation, he knows somebody's checking his inbox. He knows we're taking care of it. A good example of this happened just a couple of weeks ago. He had seen a patient who had a lump, a suspicious lump in the neck, so he sent him to get an ultrasound. By the time the guy got the ultrasound, Dr. Dean was off on vacation for 2 weeks. So I saw the ultrasound come through the inbox. I opened it up, I read it. Definitely suspicious, needs urgent referral. I'd never met the patient or talked to him or seen him, but I was able to look at the note, call him up, introduce myself, say I work with Dr. Dean and this was the finding. And by the time Dr. Dean got back, the patient already had an appointment to be seen. So it's a good example of how we can actually help with that sort of thing instead of make it more cumbersome. More time, less workload, we hope. We hope that makes a better work-life balance for the rest of the medical team. Better workforce flexibility. So just like I talked about, our docs have now, instead of working 5 days a week, they work 3.5 days a week because we have 2 PAs in the clinic, and so we pick up the slack and they can kind of step back a little bit. Increased job satisfaction, hopefully doctor retention. Potential advancement career pathway. This is one that won't be as exciting for you guys because you're already GPs, but a lot of PAs, just like Shari mentioned before, a lot of PAs were something else in their prior life, like they were a physiotherapist or they were a pharmacist or something else, and decided they wanted to do actual patient care. And so that's how they went to PA school. That's how they got to that pathway. They don't have to go all the way through medical school from day one. They can kind of get into the profession this way, which is exciting. I think it would be a partial solution to the primary care shortage. Pretty cost effective. For a full-time GP PA, it costs about $105,000 a year. Usually we tell PAs that they'll make anywhere from about $60 to $85 an hour, 85 being the ones who are doing urgent care and working long hours and have 20 years of experience kind of thing. A young workforce. Most PAs are fairly young, so they'll be around for a while. Okay, looking forward, what do we foresee the future of PAs in New Zealand to look like? For now, until we get regulated, we will continue to recruit and hopefully retain PAs. We're going to focus, our main focus is on getting PAs to rural emergency rooms, GP clinics, urgent cares. Of course, promote the role. Regulation is coming. And we anticipate that regulation and prescribing rights and scope of practice and everything else will kind of go along hand in hand all together. That's what the Ministry of Health has led us to believe, that generally that's how it works. We kind of just do all of these things at the same time so that we'll be ready at the end. The really exciting part is that we're working on talking to some universities about starting a PA training program in New Zealand. We've spoken with Aotearoa University a couple of times, the dean of the medical school. They're very interested. They, of course, want us to be regulated first before we put any money into this kind of thing, which is smart. But that's our long-term goal. We do not want this to be a bunch of foreign PAs coming over for a working holiday for 2 years and then going back home. We want this to be a profession in New Zealand with Kiwis being trained to be PAs and then going back to their hometowns and practicing. And that's really where we see it in the future. Okay, so now that you all want a PA, how do you get one? We're always happy to help, of course. You can reach out to us via our website. Also on that handout will be our email address, some resources that you can find. There are some resources for recruiters who are recruiting PAs right now in New Zealand. If you don't want to use a recruiter, we can post your job ad on our website and our Facebook page and help you in that way. We've got lots of how to hire a PA documents that we're happy to send to you. Just reach out to us and I'll get them emailed to you. We do recommend that new PAs coming over shadow a PA that's been here a while, or at least talk to them, and the society is happy to do that for you. You just let us know you've got someone coming, and we have a whole committee called the Mentorship Committee of PAs who are willing to shadow a newbie who comes over and get them used to the New Zealand healthcare system, which is really exciting.